Welcome to episode 17, which is the respiratory changes in morbid obesity. And today we're going to review the examiner's report, which is a little bit different than the ones that I've seen previously. We'll go through the literature review, presenting all the key concepts, answering questions, create an answer structure, and write an answer to time. So this is the 2017 B6 question, which is describe the effects of morbid obesity on the respiratory system. And this is the exams report, which is quite brief. So the examiner's report goes, this question required a broad consideration of the physiological and anatomical parameters which change in the respiratory system of the morbidly obese. Candidates who scored well systemically outlined the various domains of the respiratory system, listed the changes seen, and went on to describe the consequences and interrelationship of these changes. In addition, there were some marks allocated to the pathophysiology changes seen, as obesity is itself a pathology. However, a sole focus on pathology was insufficient to achieve a pass. Notably, there were no marks achieved for describing the metabolic, endocrine, or cardiovascular effects of morbid obesity. Now, this examiner's report is actually different in terms of that what he describes, or what they describe, sorry, is actually a structure rather than listing out the key concepts which they thought would achieve a pass, or also what would score additional marks as well. Now, just to summarize, what I think that they thought a really good structure would be to go through the physiological and anatomical changes, and then after that, systematically outline the domains of the respiratory system, listing all these changes, as well as the description of the consequences and relationships, and also the pathophysiological changes. Now, this is, I guess, it is an important structure. It's a basic structure. And I think, it's actually okay for you guys, if you guys want to choose this to go into the exam, having this under your belt, having this ability to use this kind of structure for not only this question, but also other questions as well. And the way that, the examiner structure we can use sort of to create the basic framework is we think about the anatomical changes, and then after that, we'll think about the physiological consequences, and then after that, the pathophysiological results as well. Now, when we think about the anatomical changes of morbid obesity, it primarily has to do with fat deposition. And from there, we can say that there's increased fat deposition in the upper airway, the chest mediastinum, and the abdomen. And these are the consequences of what happens then. So when there's increased fat deposition in the upper airway, you increase your neck circumference, increase your Mallampati score. And with that should increase your incidence of difficult intubation as well as mask ventilation as well. With the increase in fat deposition in your chest and mediastinum, that will decrease your lung volumes and decrease your chest wall compliance. And then anything that increases fat deposition in your abdomen will reduce your FRC. So with this structure already, you can see that there's actually quite a lot of concepts that you can actually talk about and expand on. And with the reduction in lung volumes, you can talk about which lung volumes are reduced and the consequences associated with that. And that can be exacerbated by your FRC. And with the reduction in FRC, that brings up a lot of other concepts that you can talk about. So with FRC, you can talk about the work of breathing. Okay. You can talk about the oxygen store, pulmonary vascular resistance, and also closing capacity as well. So this structure actually works quite well. And I think that it's one that you can easily use to approach this question. Now, the physiological changes, so just going through this again, with the upper airway, that would mean that you get difficult intubation or difficult face mask ventilation. With increased fat deposition in the chest, there's a reduction in your total lung capacity and forced vital capacity and increased work of breathing. And with a reduction in FRC from fat deposition in your abdomen, all those things I talked about before. So increased work of breathing due to a reduction in compliance and increase in resistance, a reduction in your oxygen store, an increase in your pulmonary vascular resistance, and alveolar collapse from FRC reaching closing capacity, which then causes shunt. And then the third bit would be the pathophysiological changes. And the primary one would be the association with obstructive sleep apnea. And you can talk about a number of things. So that could be hypoxic hypoxia, which leads to polycythemia, hypercapnia, which is associated with obesity hypoventilation syndrome, and then its results, which is pulmonary vasoconstriction, pulmonary hypertension, and subsequently right heart failure. So that's a basic structure using the examiner's framework. And you know what? I think that you can write a really solid answer using that format. Now, this is probably a more complicated and advanced framework. And I'll show you how I came about to create this framework. So this was the literature that I used. Primarily, it's going to be chapter 16, obesity in nun and lums. And I will also use chapter 76, power and cam, physiology of obesity, but there's only pretty much one paragraph there to summarize. So that's pretty easy. And these are the key articles that nun and lums references. So the key one is from Piper, obesity hypoventilation syndrome weighing in on therapy options in chest 2016. Okay. Now, with this framework, what are the goals? So the goals are to remember these 5 things. And the 5 things are: with morbid obesity, it decreases your lung volumes. It increases your work of breathing. There is also an increase in oxygen consumption and therefore CO2 production. There is the result of sleep disordered breathing, which is really obstructive sleep apnea, but we'll talk about it a little bit more. And then after that, that's the idea of leptin resistance or reduction in adiponectin, which we covered in the last episode, that this is a protective chemokine or adipokine. Now, I'm just going to quickly summarize power and cam, and we'll sort of go through a couple of the key concepts that he's described. And this should be hopefully nice and straightforward. And he talks about the upper airway and fat deposition, which leads to airway obstruction. And this worsens with general anesthesia, especially in the supine position. And he's quoted an incidence of difficult intubation of 13%. I'm not sure where this reference is from. And you know, with this number, I think it's fine to use for the exam. But you know, when you go through the part 2 exam, what you'll see is that it's more than just morbid obesity that results in difficult intubation. It's things like your neck circumference. It's things like your Mallampati score. And morbid obesity by itself has even been said not to be associated with difficult intubation unless you have the occurrence of a couple of key factors, which are changes in neck circumference and changes to your Mallampati score. Okay. And also with the upper airway fat deposition, it also leads to obstructive sleep apnea as well. There is a reduction in your total lung capacity, expiratory reserve volume, and also your functional residual capacity. Interestingly, your FRC decreases exponentially as your BMI increases. And this is really important, that as your FRC decreases, it reaches closing capacity, causes airway closure, and then results in shunt, causing hypoxemia, causing an increase in your AA gradient. Now, with obesity, there is an increase in oxygen consumption and CO2 production due to increased metabolic activity of adipose tissues and the workload to support the weight. And this, again, is a concept that was reinforced in the last episode with the changes of cardiovascular changes with morbid obesity. Now, interestingly, PowerCam has got some numbers here. So he said that there is an increase of work of breathing of 30%, of which the reduction in thoracic compliance contributes 55%. I am unsure of where this reference is from, and I can't reconcile it with what has been written in NUNS. So just be aware of that. I think, again, because it's written PowerCam, I think it's okay to have these numbers in your as part of your notes, but just be aware that it is a bit complex, because my question is, with the increase in work of breathing of 30%, like, isn't that based on BMI? So in other words, if there's an increase in BMI, this would increase as well. And, it'd be really interesting to see what the study is. And then, with this one here, the thoracic compliance of 55%, well, what contributes to the other 45%? Because there's airways resistance, but there's also lung compliance as well that reduces. And I will talk about those concepts as we go through the summary in NUNS. This is the figure 15.2 from NUNS, which talks about the changes in lung volumes with morbid obesity. So interestingly and importantly, your residual volume remains unchanged. Okay, potentially an MCQ question, because that's quite an interesting point, that residual volume remains unchanged. There is a reduction in your expiratory reserve volume. So this is the blue bit here. So this is with obesity. You can see that it's reduced. And subsequently, that means there's a reduction in your FRC as well. Now, in this study here from BMJ, it was shown that tidal volume does not change. All right. And looking at the study, because that concept is interesting, that tidal volume doesn't change, because I think there are a couple of studies which do show tidal volume is reduced with morbid obesity. And I think that the way to think about this is that these patients, so I looked at the paper, these patients were of probably similar height. It wasn't statistically different. There was a difference of about, I think 10 centimeters between the two groups, but it wasn't statistically significant. And I think that when you look at ideal body weight, yes, tidal volume remains unchanged. But when you consider it in terms of your total body weight, tidal volume is reduced. So that may be a way to reconcile it with other studies, or, other people who come and say that tidal volume is reduced with morbid obesity, because they could be specifically talking about it based on total body weight versus ideal body weight. Okay. Now, there is a reduction in your inspiratory reserve volume, and there is a reduction in your forced vital capacity of 13 mils for every centimeter of increase in waist circumference. This 13 is quite interesting. And look, the way that I would remember it is, 13 looks like a B, and B is for belly. And that could be a very nice and fun way to think about obesity and this number here, and how this changes with increasing obesity. All right. And 13 actually repeats itself again later on. Now, or in fact, 13 actually came about from here, incidence of difficult intubation. So there we go. That was the one from Power and Cam. So you got 13 for incidence of difficult intubation, and then 13 again for the reduction in vital capacity for every centimeter increase in weight circumference. And subsequently, there is a reduction in your total lung capacity as well. Now, why is that important? It's all to do with the work of breathing. So there is an increase in work of breathing, okay? And it's a combination of two things. So there's a reduction in your total respiratory lung compliance, and it's due to, one, a reduction in chest wall compliance from an increase in chest wall and mediastinal fat, and two, a reduction in lung compliance from that reduction in FRC from increase in abdominal contents. So you can see that this really expands on the idea of what increases the work of breathing. And I actually quite like the explanation from Nuns, because it doesn't just include chest or thoracic compliance like what Power and Cam did, but it also includes the idea that lung compliance is also reduced. And I think that helps reinforce the idea of the importance of FRC here, okay? And when we think about the increase in airways resistance, again, I really like this, so that there is an increase in airways resistance because there is one, an increase in lower airways resistance from a reduction in FRC. And we know that from the consequences of a reduction in FRC, but there is also an increase in your upper airways resistance because of increased fat deposition in the upper airway. Okay. And then your FEV1, because of the increase in airways resistance, it drops 11 mils for every centimeter in waist circumference that is increase. Okay, so a reduction of 11 mils for every centimeter in waist circumference. And again, the other important thing of this reduction in FRC is that it reaches closing capacity, causing airway closure, which results in shunt. Now, Nuns doesn't talk about the other consequences of a reduction in FRC, which is a reduction in your oxygen store and an increase in your pulmonary vascular resistance, but you can easily add that to your answer if you wanted to. This is really quite interesting, this concept here. So we know there's an increase in oxygen consumption and CO2 production in morbid obesity. The other thing that's really important is that not all patients who are morbidly obese develop hypercapnia. So some do, but some don't. And the mechanism of why hypercapnia occurs is multifactorial and most likely due to long-term conditions that cause hypercapnia, which result in this concept here, the hypercapnic ventilatory response curve, or a reduction in that curve, okay? And the mechanism of why this curve is reduced is because there is an increase in extracellular bicarbonate, which acts as a buffer to the increase in CO2. And there's also plasticity of central CO2 chemoreceptors. And this is exacerbated during sleep or obstructive sleep apnea, leading to what's called daytime hypoventilation. So obstructive hypoventilation syndrome, which is the cause of some patients with morbid obesity to be hypercapnic. Now, this is figure 15.3, and this is where my advanced framework is based on. It looks like a really busy slide, but we're going to break it down. So again, this is the end result. This is the reduced respiratory drive, and we're just going to explore the concepts here, all right? So obesity and sleep disordered breathing. So in other words, 1, 2 leads to 3. And when we look at the concept of obesity, it's got all these concepts here, which we talked about. So a reduction in lung volumes, an increase in your work of breathing, an increase in CO2 production, and leptin resistance, which we'll talk about later on. Okay, but we can pretty much highlight this all as part of obesity. So obesity leads to all of this. And just going through it, a reduction in lung volumes and an increase in work of breathing will impair your respiratory muscle performance, which will, interestingly here, so that, note this, it reduces your tidal volume. So remember before in that previous, in this previous one here, this one here has tidal volume unchanged. But as I said, the way to reconcile it is I think that this was due to RGU body weight versus total body weight. Okay, so this graph here has this as a reduction in your tidal volume. And then there's also an increase in CO2 production, which leads to an increase in your arterial CO2. So I think we can agree in this pathway here. Now, what is really interesting is when we look at this side over here, the sleep disordered breathing. Now, when I saw this diagram here, I've got two questions. The first question is, what is sleep disordered breathing exactly? And the second thing is, why are lung volumes associated with sleep disordered breathing? Or is lung volumes implicated in sleep disordered breathing? So the way that I went about this was to look at a couple of other articles. And with regards to sleep disordered breathing, this refers to a wide spectrum of sleep-related conditions that includes changes to your neuromuscular function, your upper airway size, and your airway collapsibility that increases airways resistance, okay, and leads to these three things. It leads to snoring, hypopneas, and apneas. In other words, sleep disordered breathing consists of all these three things here. And we can say that it's not the result of a reduction in lung volumes, but it's the cause of obesity itself. So I think that this diagram makes more sense if we had this arrow coming from here. Okay, and that's what I've done. And the other thing that we can say is that this is due to changes in neuromuscular function, an increase in airway size, and an increase in airway collapsibility. And this all leads to sleep disordered breathing, which consists of upper airway obstruction and sleep hypoventilation, which then leads to an increase in your arterial CO2. Now, this third bit here is, again, quite interesting. So we've got the increase in arterial CO2, and we talked about the reduction in the hypercapnic ventilatory drive due to an increase in bicarbonate, as well as due to the plasticity of CO2 chemoreceptors. So this one here, I'm pretty happy with. This one here, to explain this, I can reconcile. What confused me was this one here, where there's a direct link between hypoxia and reduced respiratory drive. I think I can reconcile this one here, but I certainly can't reconcile this direct link. So what I did was I went again to look at the original article, and this is the original article from Piper. They've got the same arrow here. And what I did was looked at the paragraph from this article, which was that sustained hypoxia delays arousal from sleep in response to external loading, and that's the reference to 19. I'm not sure what this external loading is, But they do go on to explain which could prolong periods of abnormal breathing, leading to more extreme changes in CO2 and bicarbonate before restoration of ventilation occurs. So there's no doubt that hypoxia does contribute to the reduction in respiratory drive. And what I've done is I've gone and looked at the article reference from 19, and this is what they've said. And this one makes sense to me. So this is from Sleep 2006 from Hlavac. Hypoxia impairs the arousal response to external resistive loading and airway occlusion during sleep. And what it says is hypoxic ventilatory depression in mammals is thought to result from a number of changes within the CNS, including accumulation of inhibitory neuromodulators such as GABA, endogenous opioids, and adenosine. This makes sense to me. And so with this graph here, I would get rid of this arrow here. And the altered transmitters would be GABA, endogenous opioids, and adenosine. But for this, the primary one I'll remember is going to be GABA. Okay, I think everyone knows that GABA is an inhibitory neurotransmitter, and that is actually implicated in hypoxic ventilatory decline, and that's also implicated in altitude as well. All right, and so this one and this pathway makes sense to me. Now we've got a summary. And what I've done is I've just replaced a couple of key words in here. So I've replaced the reduction in respiratory drive as obesity hypoventilation syndrome. And I've just put obstructive sleep apnea here, because by doing this, this will help me create a framework that I will understand. And I'm just going to show you here. So what I'll do is I'll say that obesity leads to a reduction in lung volumes. And from here, I'll talk about the changes that occur to total lung capacity, to FRC, and to forced vital capacity. I can talk about the increase in work of breathing, and that's, again, quite interesting with the aspects of the reduction in total respiratory lung compliance, as well as the increase in airways resistance. There is the increase in oxygen consumption and CO2 production. And I can bring in the idea of how CO2 is buffered with bicarbonate, and that leads to, and prolonged CO2 or prolonged hypercapnia will eventually lead to a reduction in the hypercapnic ventilatory response curve. And then we can talk about the sleep disordered breathing causing airway obstruction, hypoventilation, increasing your arterial CO2, causing hypoxia or hypoxemic hypoxia, which leads to hypoxic ventilatory decline. And that ultimately all leads to your obesity hypoventilation syndrome. So that's the framework that I will use to answer this question, which will cover all the aspects that I think are important. And then finally, with the idea of leptin resistance and a reduction in adiponectin, quite interestingly, this has been associated with asthma, so that patients who are morbidly obese tend to have a higher degree of asthma within that group. They also have mild COPD, and note mild, because of the obesity paradox. And I think this concept is so interesting that I have to write it in my answer. So that what is known is that there is an increased survival in morbidly obese patients with COPD, because dynamic hyperinflation actually increases your FRC. And we know that morbid obesity is associated with a reduction in FRC. So we've got one disease counteracting another disease, and this actually returns the lung to the compliant part of the curve. And this is part of the hypothesis of why patients who are morbidly obese with COPD have increased survival. So this would be the structure that I would use to describe the effects of morbid obesity. I would have my definition of morbid obesity and also acknowledging that adipose tissue is an endocrine organ. And that's very similar to what we did last week with the cardiovascular changes. So I'll probably have the same or very similar in terms of a similar opening line. And then after that, I'll have these on as my subheadings. So morbid obesity leads to lung volumes. I'll have worker breathing, because I know worker breathing is a big one. I'll have the worker breathing on a new page. And then I'll have the increase in oxygen consumption and CO2 production, probably about 3/4 of the way down. And then I'd have sleep disorder breathing on a new page, and leptin resistance and adiponectin probably about halfway down. All right, so everyone get their pens ready. Got my stopwatch. And let's go. So I'm going to start off with my definition. And then after that, I'm going to have a reduction in lung volumes. Right to that. 2, I'm going to have the increase in work of breathing. 3, I'm going to have increase in oxygen consumption and CO2 production. 4, I'll have sleep disordered breathing. And 5, I'll have leptin resistance, a reduction in adiponectins. All right, definition: morbid obesity equals BMI more than 40 or more than 35 with comorbidities, results in respiratory changes because of 1, excess adipose tissue, and 2, early metabolic and endocrine organ. This adipose tissue is a highly metabolic and endocrine organ. Okay. So reduction in lung volumes, there is a reduction in total lung capacity, a reduction in your expiratory reserve volume, and a reduction in your inspiratory reserve volume, a reduction in your vital capacity, so 13 mils every centimeter in waist circumference. FRC decreases exponentially with increasing BMI, reaches closing capacity, causing airway collapse and shunt, worsened in supine position, and general anesthesia. Okay, increase in work breathing is due to a reduction in 1, reduction in compliance, due to reduction in chest wall, due to increase chest wall and mediastinum fat. There's also reduction in lung compliance due to decrease in FRC from increased abdominal contents, and 2, increase in airways resistance from increase in lower airways, from decreased FRC, increase in upper airways, from increase fat deposition there. And again, worsened in supine position and anesthesia. I can say FEV1 decreases by 11 mils for every centimeter in waist circumference. Okay, so with the increase in oxygen consumption and CO2 production may lead to hypercapnia from decrease hypercapnic ventilatory response curve due to an increase in extracellular bicarbonate, which has a buffer CO2, and also to the plasticity of CO2 chemoreceptors, and this contributes to obesity ventilation syndrome. HS, because I'll probably repeat that somewhere. Sleep disordered breathing, obstructive sleep apnea leads to increase in nocturnal CO2, decreases nocturnal O2, leading to hypoxia, and long-term may cause ventilatory decline from increase in GABA, endogenous opioids, and adenosine. And probably, as in here, increases difficult intubation and mass ventilation. Okay, leptin resistance. So along with decreased respiratory mechanics, decrease hypercapnic ventilatory response, and hypoxic ventilatory decline. This culminates in OHS. Also associated with asthma, mild COPD. Okay, last minute note. obesity paradox describes increased survival due to dynamic hyperinflation, increasing FRC, counteracting decreased FRC, and returning curve to favorable part of White's curve. All right. Line 45. Okay, that's 10 minutes. So that's my answer here. I'll show you. I've got my definition, my reduction in lung volumes, and then I've got my increase in worker breathing, my increase in oxygen consumption and CO2 production, and my sleep disorder breathing, and the idea of leptin resistance and a reduction in adiponectins.